Hello, everyone. Welcome to another edition of the FASMBS Bariatric Happy Hour. I am delighted to report that we have tonight Dr. Ted Adams, Dr. Hunt, joining us to talk about some long-term mortality results after bariatric surgery. First, I want to start off with a couple announcements. So the FASMBS annual meeting is coming up very, very soon. It's in San Diego from the 9th to the 13th of June. We have a number of really important talks, some great papers that will be presented as well. I'd like to remind you guys that it provides another opportunity to get certified with Be Safe. We'll be offering 2 sessions on Monday, the 10th of June. Prior to the annual meeting, we also have a day-long celebration of Dr. Pori's. He's a surgical giant in our field. If you guys are not aware, please check the website, which we'll try to post in the chat later today. But you guys have been officially invited by the FASMBS, and I think it would be a great opportunity for you guys to come. The next thing to announce is that the Fellow Project, in June, we'll be having a session on bariatric surgery and pregnancy. We'll have speakers, Dr. Renee Hilton and Dr. Rich Peterson will be there. And then the next edition of the FASMBS Bariatric Happy Hour will be a video session, but today we'll be doing Journal Club. All right, so let's get to the Journal Club. As I mentioned, we have Dr. Ted Adams with us. He's an adjunct professor in the Genetic Epidemiology Research Program within the Division of Epidemiology at the University of Utah. He himself is a Utah native. He completed 2 doctorate degrees, one in exercise physiology and the other one in public health. He has been funded by the NIH and produced over 100 well-cited publications, including tonight's landmark articles that we'll be discussing. We're also joined by his co-author and partner in bariatric research, Dr. Stephen Hunt. He is a professor in the cardiovascular genetics division at the University of Utah. His research is really centered around genetic and environmental causes of cardiovascular disease, with a focus on hypertension and obesity. He's trained in biostatistics, genetic epidemiology, physiology, and computer applications to biomedical research. And he also has multiple research grants in these fields. We're delighted to have both of you guys. We also have joining us Dr. Adrian Dan, who is a dedicated metabolic and bariatric surgeon in Akron, Ohio. He's the program director of the Advanced GI MIS Foregut and Bariatric Surgery Fellowship Program. He earned his medical degree from Northeast Ohio Medical University and completed his general surgery residency at Michigan State University. His expertise was further refined through a prestigious fellowship at the Cleveland Clinic. And Dr. Dan is the chair of the Bariatric Surgery Training Committee. He has really helped to transform the way that we train our bariatric fellows, and I'm just honored to call him a friend. So thank you to Dr. Dan for being here. All right, almost done with the introductions. Dr. Gill-Wiehl is our special fellow tonight, and I have to give her 1,000 thanks for stepping up at the last minute to present this paper, so thank you so much for that. She received her MD and MPH degrees from the University of Miami in Florida, and then did her general surgery residency at Rush University Medical Center with the integrated program in Chicago, Illinois. She is currently the MIS Bariatric Fellow at Yale in Connecticut and plans to return to Chicago to join the faculty at Stroger Cook County Hospital in the fall. We obviously wish you luck. All right, Laura, we all know you, so I'm going to skip the introduction on you tonight. And just try to get straight to the paper because we have a lot to discuss. All right, Dr. Gill-Wiehl, go ahead and put up your PowerPoint.
Can we all see the slides?
Yes, looks great.
Wonderful. Let's get started. It's a privilege to be here with the authors of these studies to be able to discuss them, and I'm looking forward to a really nice discussion. The 2 articles that we'll be discussing tonight are long-term mortality after gastric bypass surgery and from the New England Journal of Medicine, published in 2007, and then next we'll talk about long-term all-cause and cause-specific mortality for 4 bariatric surgery procedures. published in Obesity Journal, published in 2022, both with Dr. Adams and Dr. Hunt. So the background for both articles really is there is a positive association, as we know, between obesity and an increased rate of death. However, there is fairly limited long-term data on mortality after bariatric surgery, posing the question of, does bariatric surgery lead to increased longevity? And so the aim of really both of these papers was to add to the literature and conduct retrospective cohort studies to compare long-term rates of death from any cause and specific causes in patients who had undergone bariatric surgery. Specifically in this paper, they looked at the gastric bypass, which was the most prevalent procedure at the time, and they used a control group of severely obese subjects pulled from the Utah database. So this first paper looked at long-term mortality from 1984 to 2002. It was a single institution study that looked at 9,949 patients who had undergone gastric bypass surgery, and they matched these patients to 9,628 patients with severe obesity who had applied for driver's licenses in Utah. And then from that cohort, they pulled 7,925 patients for each group, and they matched them for age, sex, and BMI. And then looking at this data, they determined the rates of death from any cause and from specific causes using the National Death Index. To conduct these statistics, they used a Cox proportional hazards regression analysis. So again, the primary outcome was death from any cause, and the secondary outcome was looking at specific causes. And you can see the table 1 baseline characteristics. I don't think it would surprise anyone that the majority of patients were female. The average age was 39.3 years old. The average BMI was about 44 to 47. And in the matched subjects, there were 213 deaths out of the 7,925. And in the control group, there were 321 deaths out of the 7,925. And the mean follow-up was 7.1 years for both groups. So looking at the results of the study, the adjusted long-term mortality from any cause in the surgery group actually decreased by 40% compared with the control group. So it's 37.6 versus 57.1 deaths per 10,000 person years. And this was statistically significant with a p-value of less than 0.001. When they looked at cause-specific mortality in the surgery group, it actually decreased by 56% for coronary artery disease, 92% for diabetes, and 60% for cancer. So this was quite significant. The rates of death not caused by disease, so this would include things like accidents and suicide, however, were actually 58% higher in the surgery group compared to the control group. And that was a rate of 11.1 versus 6.4 per 10,000 person years, which was also statistically significant. Something that the article commented on was the number of deaths from disease prevented, and they calculated 171 deaths from disease prevented per 10,000 operations. However, there was also an increase of 35 non-disease related deaths. So the things like accidents and suicide per 10,000 operations for a net total total prevented deaths of 136. This is a table looking at the distribution of the deaths per 10,000 person years. And as you can see, cardiovascular disease had a significant lower rate in the surgery group. Deaths from diabetes also had a much lower rate in the surgery group. but you can also see the non-disease causes had a higher rate compared to the control group. And then they use this to calculate hazard ratios. And we can see the hazard ratios there in the 95% confidence intervals. The one in boxes were statistically significant, as I've mentioned, for all cardiovascular disease, specifically coronary artery disease, diabetes. Cancer was also statistically significant as well. And then to look at this in a Kaplan-Meier survival curve, we can see that the 1-year survival was very similar, if not essentially the same, in the groups. And then you can see the trend over the follow-up. So if we look at up to 18 years here, the control group has a statistically higher chance of mortality compared to the surgery group. And I thought that was a very nice graphical reference. So, some of the limitations of a study like this, unfortunately, just due to the nature of the data, there's no comorbidity data on the non-surgical or surgical patients. This obviously leads to questions. Sicker patients may not be surgical candidates and might have a higher mortality, or, we just don't know enough data to make comparisons along those lines. But that's really kind of the nature of the data, unfortunately. The other thing was we didn't have specific weight loss information, so it was difficult to correlate higher weight loss with perhaps a longer longevity. And then the time frames, things have obviously changed in terms of the surgeries that we offer from the 1980s and even early 2000s to now, which is really where the next study comes in. But just kind of in conclusion, we can draw from the study that gastric bypass patients have significantly reduced long-term mortality rates compared to non-surgical obese patients, and especially when looking at heart disease, diabetes, and cancer. Are there any questions right now, or should we move along to the second article?
You can move along to the second, and then we can do our full discussion after.
Perfect. So the second article really builds on the information we gathered from the first article and attempts to provide a even longer follow-up. So we kind of went over the background when we talked about the first paper, but this paper expanded upon that to include different procedures, including gastric banding, the sleeve, duodenal switch, as well as the gastric bypass, and also looked at if there was a difference between genders, as previous studies prior to this had not necessarily shown reduced mortality among male surgical population. But again, that population is significantly smaller, and so the effects may be harder to ascertain. So the primary aim of this study was to determine the association of all-cause and cause-specific mortality risk between bariatric surgery patients and matched non-surgery participants. And then a secondary aim was to determine whether the age at surgery influenced mortality outcomes and whether mortality rates differed between sexes and between surgical procedures. So this, again, used the Utah population database and looked at patients from 3 bariatric practices. As I mentioned, this expanded the procedures that these patients were undergoing, and they matched 837 surgical patients with 21,837 non-surgical patients. So really quite a robust cohort. The surgery and non-surgery patients were matched 1-to-1 for age, sex, BMI, and surgery date. And then they again used the Cox proportional hazard models to perform statistical analysis. You can see here their inclusion and exclusion criteria and how they were able to gather these two different groups of surgical and non-surgical subjects. So if we look here at the distribution, overall, the majority of patients, again, were female. To just tell you guys a little bit about the participants in the group, the most common procedure was the Roux-en-Y gastric bypass at about 69.2%, followed by the sleeve. With this data, they were able to include up to 40 years of follow-up, but the median time of follow-up was 10.8 years. There were 2,943 deaths for the surgery patients out of the 21,837, and 3,181 deaths for non-surgery patients. So that was 13.5% compared to 14.6%. The first year mortality was very similar among surgical and non-surgical patients. So in the first year, there was a 0.5% versus 0.4%. The mean age for enrolling in the study was 42.2 years versus 42.3 years. And if you look overall, the rate of death from all causes was 16% lower in the surgery compared with non-surgery groups for all the years of follow-up. And the total mortality was lower for both males and females, and it was significantly lower for diabetes, cardiovascular disease, cancer, and chronic lung disease. Of note, chronic liver disease actually had a higher number of deaths in the surgery group compared to the non-surgery group. And again, unfortunately, external cause deaths, so that includes, again, things like accidents and suicide, were significantly higher in the surgery group. Suicide was actually 140% higher in the surgery group. There were 44 suicide deaths compared with there were 112 in the surgery group compared with 44 in the non-surgery group. And so this is the distribution and death rates table. And then here we can see the hazard ratio as a graphical format. And overall, we can see that the all-cause mortality, as I mentioned, was 16% lower in the surgery group compared with the non-surgery group. And again, significant decreases of 29, 43, and 72% for cardiovascular disease, cancer, and diabetes, respectively. And the survival time for all cause of death was an additional 1.3 years in the surgery group compared to the non-surgery group. On this table here, just to talk about this briefly, up here at the top, you can see all causes broken down by the type of procedure. So gastric bypass up here at the top, followed by bands and sleeve, all had statistically significant lower rates of death compared to the matched non-surgical cohort. There were only 61 duodenal switches looked at, and they had an increased risk of death, but that was a fairly small number. And as you can see, the confidence interval crosses 1. Looking at specific limitations for this article, similar to the first article in terms of weight loss data and lack of clinical information on the specific patients. Also, the bypass had been around for longer than the sleeve, and so there was a shorter follow-up time for patients undergoing sleeve procedure. So, hard to say if there would be a difference between those groups if they had been followed for the same amount of time. And so kind of conclusions of this Study again demonstrated a lower all-cause mortality in both male and female patients undergoing bariatric surgery compared to their matched cohort. The gastric bypass, banding, and sleeve all had a lower total mortality risk for surgery compared with non-surgery. The rate of death from suicide was unfortunately 140% higher in the surgery cohort, and that was especially true in a specific age group, which were patients who were 18 to 34 undergoing bariatric surgery. And the article, recommends that we should definitely consider more aggressive pre-surgical screening and post-surgical follow-up in these patients. So that's a summary of the articles, and
That's great, Genevieve. Thank you. I'd like to invite our guest discussants to now make some commentary.
You'd like to invite Dr. Hunt and myself to make commentary, you say?
Yes, please. We'd love to hear
Okay.
from you.
Great. I just lost our the picture here. Let's see. I can do that.
I stopped sharing.
Can you hear me okay? I've lost the
Yes, we can hear you.
you can hear me okay. I can't see your faces, but anyway, thank you so much for that nice review. I appreciate that. Dr. Hunt and I appreciate being with you today. There are just a couple of comments I would like to make. One comment that a number of people have said is or raised about these two studies is you've used driver's license applicants. We know that people tend to fudge when they apply for their driver's license and renew their driver's license. People tend to report a lower weight than they really are, and particularly if they're overweight, and they also tend to say they're a little taller. And so we were able to determine the reported height and weight on a driver's license application of about 700 patients who a few months later or within a year later went on to have bariatric surgery, and the actual height and weight were measured pre-surgical during their pre-surgical exam. And so we were able to develop some regression equations to correct for that, I'll call it a fudge factor on reporting your driver's license. So all of the statistics that were reviewed today, the control group, the driver's license group, their self-reported heights and weights were all adjusted using these regression equations, which bump their tend to bump their weight up as well as reduce their height somewhat. So I wanted to mention that. Another comment, and I'll ask Dr. Hunt to comment on this too, is you mentioned in your review that one of the limitations is that the non-surgical group may represent a sicker patient population and therefore may not be assigned or okay to have surgical procedures for bariatric procedures. And we have actually conducted a 12-year prospective study where we looked at patients who were seeking gastric bypass and went on to have bypass surgery. A second group of patients who were seeking gastric bypass surgery but did not have the surgery, primarily due to insurance not covering it. And then we looked at a third group of matched population, randomly chosen patients not seeking surgery but were severely obese in the class 2 and above degree of obesity. and we followed them for 12 years. But what I wanted to mention is that at baseline, the health parameters, the comorbidity measurements, that sort of thing, they were all pretty similar, which gave us some confidence that the driver's license applicants may not have necessarily been a sicker population just because of this prospective study we did. Dr. Hunt, do you have anything to add to that?
No, except it still might apply to those with the higher liver disease, because we didn't do a real good assessment of liver disease in this study, in our longitudinal study. We could have missed people who had undiagnosed liver disease in all of our studies. And those numbers were still somewhat small. So that finding certainly needs to be replicated before we put a lot of weight on it, I believe.
Yeah, that's very interesting, actually, because I think in most of our practices, patients don't routinely get screened for liver disease when they come in and are diagnosed with obesity. So I think there's a huge portion of the population that goes undiagnosed. Dr. Dan, please, I'd love you to jump in at this
So
point.
first I want to say, Genevieve, great job reviewing the article. Dr. Adams and Dr. Hunt, I want to congratulate the two of you on really a couple of the most important articles over the last quarter century in metabolic and bariatric surgery. And Julianne and Laura, thank you guys for bringing these two great scientists to speak to our fellows. So a little bit of history and background. Dr. Adams, 2007 at Snowbird in Utah. I was actually in the audience when you first unleashed upon the world, before the New England Journal of Medicine even published it, some of this data, of course, with not the whole thing, but some of the stuff, and the whole audience was wowed, and we were we were witness to an amazing publication that was to follow. At the time, for the fellows, at the time we only had very minimal data on how metabolic and bariatric surgery affects longevity. Dr. Christo's study from McGill in Montreal showed an 89% reduction in mortality, but the methodology of that, which is described in the 2007 Adams paper, is certainly, it compares the two methodologies. There's quite a bit of difference there. And now we had very, very sound methodology, and the degree to which this paper went to Dr. Hunt and Dr. Adams to make sure that that it's well done, and it really there's very few statistical things that you can fault it with. There's really nothing. That really made it really good evidence that we as bariatric surgeons were able to use really for the next 2 decades. I've beat this drum since 2007 when I was a first year attending. Every seminar I give, every time I meet with a primary care doctor, an endocrinologist, a patient that has some doubts. Does it matter what the biomarkers show? Does it matter if your blood pressure is 135 systolic versus 125? Hemoglobin A1C is 6.2 versus 6.4. I'm not sure, but it matters when the endpoint, the outcome, is mortality. So the two of you have saved countless lives. You can do the math, the statistics, how many bariatric operations have been done, and the 40% reduction in overall mortality. You guys have had a hand in truly having a lot of people believe in the potential of metabolic and bariatric surgery. So with that, I'm gonna tell you that there's very few papers I can point to over the past 20 years that I've been in practice that we've used with such conviction and have been able to change minds as your papers. They've done a lot. They've made a huge difference. So that's how it's affected my practice over the last 20 years, and that's my 2 cents on that. When you can tell somebody that it reduces diabetes-related mortality by 92%, that's some pretty powerful stuff.
Well, thank you for that nice compliment. I remember that Snowbird meeting, and I remember Dr. Sugarman and Dr. Schauer and others saying, you know, are you going to publish this? And my comment was, yes, we've submitted it to the New England Journal of Medicine, and it literally took us 18 months to finally get it published, back and forth with the reviewers. The scrutiny was pretty intense, and I think part of the delay, they were aware that the SOS group, the Swedish obesity study subjects group, had also submitted their first mortality paper to the New England Journal, and that was being reviewed. And they finally, the New England Journal editor finally said, you know, we're kind of delaying yours and kind of theirs, because we want to publish these two studies in the same journal edition. And so
Same issue.
so that was nice to be able to have both the SOS and the you know, United States-based study published at the time, and really banding was not had really not been approved at that point, and sleeve was not being done, and so that's why the gastric bypass patients were the only the cohort in that study.
Dr. Adams, just to expand on that a little bit, nothing to take away from the SOS study, or some of the best data that we have for metabolic and bariatric surgery. But unlike your 2023 paper, their data and their study is based on procedures that are completely obsolete. Matter of fact, I want to say almost 70% of their procedures were vertical banded gastroplasties, and that's just not what we do anymore. It doesn't really, and I, you know, when we continue to put out data and literature on procedures that are obsolete and don't compare to the innovative and refined procedures we have today, we're kind of misleading ourselves into thinking that our capabilities are not as good as they truly are, especially when we're trying to put them up against anti-obesity medications and some of the endoscopic procedures. So just a warning to our fellows, the data that we should look at is the one that looks at the contemporary operations, and the 2023 paper that Genevieve reviewed looks at band, sleeve, bypass, and duodenal switch, and that's what we do now. So.
And actually that second paper also included SADIs, Adrian. So I thought that was really, you know, spot on in terms of keeping our research more modern. So I agree with you. You mentioned the medications, and you know, as I was reading the article, I did wonder whether the effect that we're seeing is just from overall weight loss, or is this really like a metabolic change as a result of the medication, I mean, of the surgeries. How do you guys think these numbers would look? And I know we don't have the data yet, but how do you think they would look with patients who are on the medications? Do you think that the results would be similar?
Ed,
Or
you want to take a stab at that?
Or Dr. Adams and Hunt.
Well, I was asking the panelists in general, so you guys feel free to jump in. Anyone can
From a
tackle.
clinical standpoint, I would say that, look, the anti-obesity medications are just another tool in our arsenal. And many people are hoping and studying on how we can utilize them, not in lieu of surgery, but along with surgery, combined modalities that we can fight obesity with. So if we use medical therapy to expand upon the benefits that are conferred by surgery, I think that over time we're probably going to see even better improvement of longevity and decrease in mortality.
So I have a comment on this. Ted mentioned our 12-year longitudinal study. So this study has allowed us to look at the metabolomic panels and the proteomic panels and microRNA panels in these subjects. And the thing that we've learned there is as we have looked at weight loss versus some of these endpoints like diabetes, blood pressure, and when you adjust for the amount of weight loss, it does take away some of the effect, but there's still something left there that is not just weight loss. And you see that with metabolites, you see that with the proteins in the blood, that you can adjust for weight loss. Some of the metabolites will normalize as though all those changes in the metabolites are due to the weight loss, but there's a significant subset that are still independent. So I think that the surgery is doing something beyond just the common metabolic things that we're measuring.
Well, and there's some data out of Europe doing bypasses in patients with normal weight, and they do still get a 30% remission of diabetes and a 30% improvement. So I believe that there's some non-weight loss related benefit to what we do, but I think it's hard to tease it out because certainly the weight loss decreases the adipose tissue, and then that decreases your inflammatory cytokines. And
right, and the telling factor in who resolves for diabetes is medication status and the length of time they've had diabetes. So the people who didn't resolve their diabetes are those that have been diabetic for a long time, mostly on insulin. And so that would suggest that you don't wait till they get severe diabetes before you do the surgery.
mm-hmm. How did you guys, I'm curious, how did you select your control group? And was that difficult, and what things did you think about? Because I think it's really hard to get good comparative data in bariatric surgery, and prospective randomized controlled trials are very, very difficult and expensive.
I'll just give a quick answer, and then Dr. Hunt can add to my comment if you'd like. We actually went through several million driver's license records using microfiche, because this was before the driver's license records were digitized, and we extracted any patient who had a self-reported BMI of class 2 or greater than 35. And the latter years, we did have some digitized information so we could draw upon that electronically, but it took us a good almost 2 years to extract all of that data. And then using that, we did a match with the surgical patients, matching the year that they had the surgery with the year that they renewed their driver's license, as well as their age and sex. And then we used the regression equations to adjust for their self-reported height and weight, so that it would be more accurately matched to the surgical's measured height and weight. And so that's how we actually were able to get those patients. In the second study, now all of the driver's license records are electronically obtainable, and we worked through the Utah population database to pull those controls. But that is how we did that in the mortality study that you two have reviewed. It was a different approach with the prospective study, but that's how we did the retrospective study. Steve, do you have anything to add to that?
No, I don't.
I do want to mention when this paper was first published, I remember the day it came out, I was on a bus just having been picked up at the airport. I think it was in New Orleans, and Tom Wadden, I don't know if you know his name. He's been a major scientist in weight loss techniques, and he happened to be on the bus, and he said, "I just read your paper, and I can tell you that the disturbing part about this is the increased number of deaths from the external causes, and the phone calls from actually around the world came in pretty rapidly over the next couple of days, and many of them said basically, is this a Utah thing?" And so for some time I worried, I certainly hope our statistics are accurately reflecting this. It's not a Utah thing, that the increased external causes of death. As you know, since that time, there have been multiple studies showing the same thing, and I'm not sure exactly the reason for that. I know groups looking at that. Our most recent study suggested that it was primarily in the population who had the surgery. Age was under 35. On the safety board for the teen lab study, and there have been some suicides and overdoses in that population. And so how we address that, I'm not sure if it's surgery procedure specific, but that, and it's not a major number. It just happens to be significant. And so I salute those of you that are continuing to care for the patients, and I'm sure answers will come, and corrections or specific methodology will come along. That statistic, throw that out as a comment.
Did you have a question, Genevieve? I thought I saw you speaking, but I couldn't hear you.
I was going to ask, and Dr. Adams kind of touched on this a little bit, but in general, if you had any idea of how the Utah demographics compared nationally.
That's a good question.
I'll let Steve answer that. Steve.
Utah generally has a high suicide rate compared to the rest of the nation. And there's a lot of genetic studies going on to look at some of the genetic underpinnings of that, because it's certainly running in families, and obesity could certainly help with that. And of course, the theory is that these people that are overweight think that this is going to solve all of their social problems, and they have the surgery and it improves their physical health, but it doesn't improve their emotional, social health.
And I think it also can interfere with medication absorption and efficacy, because we definitely have a lot of people who have to change their antidepressants or anti-anxiety medications after surgery and go up or down on the dose, or change actual types of medication.
Yeah, I agree with that. Dr. Mitchell has published a really nice review of all of the possible reasons, and one is what you just said, the medication absorption, and so again, that may be procedure specific.
Were you guys surprised by the significant increase in suicide rate?
Yes, I was surprised, even though it was not significant in our first study.
Right.
But it wasn't the second. I
Hmm.
was surprised, and again, concerned that I had so many people challenging that, because we were kind of the first group to really bring that, to really publish that, and so, but other studies began to show the same thing.
Mm-hmm.
Yes, it's a real thing, but as Dr. Hunt has said, there is with a slightly higher suicide rate in our population, rest of the nation. The SOS, I was at a meeting when I presented this initially at a meeting, and Dr. Sostrom from the SOS in his talk said, we have no suicide, we don't have any suicides. But later the SOS has now published that has been part of their findings, that there is an increase in external deaths. But I hate to dwell on that too much because it's a smaller number, and I'd hate to detract from the many benefits that we've demonstrated in these papers, as well as the prospective study. And I think the medication, personally, I'm not sure it's going to have the broad, Dr. Hunt has said, this significant subset of independent benefits aside from weight loss. It'll be interesting to see if the medication story unfolds in such a dramatic way as the bariatric surgery. I kind of don't think it will, but certainly a nice opportunity to do some randomized control trials with surgery and medication, just to tease that out.
Yeah, I agree with you, Dr. Adams. I think there have been a couple small publications looking at the bypass versus the GLP-1 semaglutide specifically. And they've already shown that patients who have had bariatric surgery are able to get off medications, as opposed to the semaglutide patients 5 years out, they're still requiring some kind of medication for their chronic weight-related comorbidities. So I think there continues to be added benefits to having bariatric surgery, even if patients are not necessarily aware of it. I do want to just make one more point about the suicide rates, which is that, most of us now are in multidisciplinary practices, and we always get our patients evaluated by a psychologist. And I think the focus is really on having the psychologist see the patient before surgery. And there probably is not enough support that we're offering to the patients post-operatively. I know even in my practice and in the practice of a lot of my colleagues that I know personally, we're all kind of doing the same thing. The patients typically will not see the psychologist afterwards. It really is, they're dependent on their regular psychiatrist or therapist that they had been seeing before. And we probably need to get the bariatric psychologist more involved post-operatively.
Yeah, we added in a 6-month visit with our psychologist as part of our program about 1.5 years ago, because that was when we noticed that people started kind of heading back into their old habits, because the excitement of surgery was wearing off. And it has been incredibly helpful. And we've really helped to kind of capture people at a really good time to help them re-establish their new kind of habits and continue that connection, and then do some interventions. But I agree, there's a lot of significant changes to all of the different factors of your life after surgery. It's not just weight loss, it changes your interpersonal relationships with your family, your spouse. It changes how people treat you when you walk around. And so all of these amazing things like curing your diabetes and curing your high blood pressure, and helping you live longer and feeling better and having great energy every day. It's not 100%, free. There is some challenge to it. And some of it, I think, comes on the behavioral health side.
Well, I commend you all for in those components, the behavioral aspect. I do want to say again that even one suicide death is certainly a concern. The overall population number for both studies, the external deaths, although they're significantly greater in the bariatric surgery group, there is still a relatively small number. But nevertheless, it certainly gets our attention and warrants the actions or steps you are taking, and that's wonderful.
Were you all surprised at all about kind of the distribution of mortality benefit for the different categories of comorbidity, like diabetes versus cardiovascular versus cancer? It seems to me, I wasn't, I was a little younger, so I wasn't in training when I was in medical school when these papers came out. But it seems to me that in particular, the magnitude of the mortality benefit for patients with diabetes and the cancer mortality benefit seemed quite surprising to everyone at the time. And I was just curious.
I'm glad you mentioned that. And by the way, you've kind of indirectly let everyone know how old Dr. Hunt and I are. You were in grade school when we published this paper, it sounds like, but
No, medical school. I was born in the 70s. It's okay.
I'm just kidding, but quite. But the surprising thing for Dr. Hunt, myself, and our colleagues, we were very surprised to see this 60% reduction in cancer, because the follow-up time was not that long, and yet cancer mortality, you kind of, our thought was cancer, take much longer follow-up to really see a change in cancer, and so so we followed up with that and published soon after the New England paper a cancer study looking at cancer incidence and cancer stages and that sort of thing, and very striking findings. And of course, now there have been dozens of studies showing the same thing, and so I continue to think that's pretty remarkable that cancer incidence can be so impacted, and as well as the cancer mortality. So not only lower death rate with cancer, but much significantly lower incidence. And this is really a remarkable finding, I think.
And to add to that, it's the decreased incidence of cancer appears to be dose dependent, is what a lot of recent literature is showing us. So that's why it's so nice to see a paper that actually has a granularity of looking at decreased mortality and increased longevity amongst different procedures that give you more or less weight loss. And then we can also extrapolate what the obesity medications can do compared to those surgeries. So there is a lot of benefit, not only with regards to decreasing incidence of cancer, but also survivorship. And it's dose dependent based on the amount of loss.
That is the Dr. Mania is
Exactly.
There in Cleveland, as you know, did show that dose dependent response for cancer reduction. And
that's exactly the paper I had in mind. And one last comment for me to make is Dr. Adams, Dr. Hunt, how long are we going to be studying this out? Because eventually the two curves have to converge back to the same.
Thanks for reminding us all, Dr. Dan.
Well, isn't it quality of life that counts though? But I will let you guys answer that question.
It wasn't a real question, but there has to be a point where it doesn't appear to be as beneficial anymore, of course. So maybe you can comment on that.
Say your question again.
I was just joking that eventually the two curves will eventually have to converge back as people live out their number of years.
Oh, I see. Steve, do you want to comment on that?
Well, that will happen, but as has already been mentioned, if you have a better quality of life and you're taking fewer medications during that, if you can delay diabetes 10 years even, that's great. I mean, you have 10 years less of damage to your arteries. So the quality of your life and the medication status is very important. That's what people care about.
See patients in pre-op and they tell us about their goals. You know, one thing I hear over and over again is they want to live longer. They want to see their kids, their grandkids grow up. And it's really nice to, you know, have this literature to point to that say, yes, this can help you. So.
Yeah, and I sometimes get a little frustrated when there's a lot of focus on the ways in which bariatric surgery fails, or in quotes, or doesn't meet these extremely high expectations, like, you know, 25 or 30% of patients eventually having some obesity recurrence. And, you know, like you said, Dr. Hunt, being off of diabetes medications for an extra 10 years. I mean, even if you do eventually get diabetes, you still get a massive benefit compared to not to having your diabetes, you know, start in your 30s compared to your 40s. You know, it might be the same slope, but because you're starting so much later in life, you get that many more years and that much less damage to your end organs. And so I do think that kind of reframing it a little bit from saying, you know, you have to have 100% diabetes cure at 6.0 on no medications or else it doesn't count is not maybe the best way to look at some of our outcomes. It's the easiest way to measure it in a database because it's like a yes, no, but the nuance of the benefit of improvement is lost.
I love that you brought that up, Laura. It's incredible what standards our therapies are held to compared to other therapies. So if you look at the, you know, I heard somebody say once that when medical therapy loses 5 to 10% of excess body weight, they dance in the streets, right? But if you get that with surgery, and it's like that's all you could do. So there's nothing to reframe things and remind us of what they can do by than pointing to these drastic decreases in disease-specific mortality. So just to kind of bring it all back home.
And I salute that, both of those comments. And the prospective study that we took out to 12 years, Steve, help me if I'm off on this a little bit, but there were just a handful, a very small percentage of the surgical patients who gained all their weight back. It was I think 4 or 5% or less. I mean, it was not you know, it was I think in the news world you just hear that again, you know, of those people that do gain their weight back was very few in our study. Isn't that correct, Steve?
Yep, only 4 people gained all their weight back or more out of the
4 people, and that was out of 321 or something to begin with. We followed for 12 years. And after 12 years, by the way, the weight loss on average was 27%, started with 35%, but and between 6 and 12 years, it stayed level, 26, 27%. And as Steve mentioned, only 4 people gained all their weight back. So pretty remarkable. I want to say also that one of the grand things about our research is the surgeons we worked with, they were so nice when I approached them to let us have all of their data. And they, not once did they try and persuade us to have the results go one way or another. They just simply gave us all the support, and really there were no surgeons involved in the research other than we recognize them as having been the surgeons. And so this certainly, I can say with confidence, was not biased at all. Our research has never been biased by an undue influence by a bariatric surgeon or their staff that have been so gracious to work with us. And so I've been very impressed with the support we have had and the support of the patients, of course.
You know, as you were talking, Dr. Adams, I actually was thinking about the impact that these types of publications have on our patients, because I think now most patients might be a little hesitant to undergo surgery, especially in the face of the new medications. But I think when we look at cold hard data like this, it really just supports the benefits of bariatric surgery. And I mean, I know you made those comments about the surgeons not being on the paper, but ultimately what you guys have published has been really you guys have made such a significant contribution to the field. And anyone can look at it and say objectively that the bariatric surgery is really, really good for patients. So thank you guys for even publishing that. Thank you guys for coming on, taking the time to talk with us. We are at the end of the hour and I don't want to keep people much longer, but I really just want to express our gratitude. Thanks to Genevieve again for coming on, late in the game, and Dr. Dan as well. To everyone at ASMBS, I did go through the announcements before, so I won't actually repeat them, but the next session will be a video session, and we're hoping to talk about bariatric complications. Thank you guys. I hope you have a good night.
Thank you very much.
Yeah.
Thank you.